Hi, everyone. I'm Jaime Madrigano. It's really a pleasure to be here today, and I'm going to be talking a little bit about my climate and health research and how using different types of data local data can inform local policy solutions to a global problem. Okay, so just to set the stage a little bit, although I probably don't necessarily need to do this, especially with news of the day, but these are some statistics from NOAA, and this graphic is just showing over the course of a year, this data is from about the last 40 years, looking at the number of billion-dollar climate and weather disasters that occur each year. The solid black line is the historical average over this roughly 40-year period. But what I want to point out is the colored lines are all years from about the more recent years, so roughly within the last decade. So you can see that we are now, with climate change, we're exceeding those historical averages. So on average, for this 40 or so year period, we hit about $6 billion weather-related disasters each year. But now in recent years, we're seeing more like 14, 16, some of the highest numbers. I just was able to clip this from the New York Times today. As we already heard earlier, the death count is about 20, but probably rising by now. And this is a picture of Dorian today. So with that, I wanted to talk just really broadly about some of the health impacts from these climate-related events. This is a schematic from the CDC, and you can see that in the center circle are the climate phenomena that we're seeing with climate change: increasing temperatures, more extreme weather, and then that next circle describes the types of events that we're seeing more and more of. So extreme heat events, severe weather, such as hurricanes and extreme floods, changes in vector ecology. And then on the outside are some of the health impacts that we know of. I want to emphasize some because this is not a comprehensive list. And, I want to touch on some of that because, for example, so we know that we see rises in heat-related illness during extreme heat waves. We also see that with severe weather like hurricanes, we see injuries and fatalities. But aside from those very directly attributable types of health impacts, we also know that there are chronic disease exacerbations, and I'm going to talk about that a little bit later in the talk. So how can climate and health research inform policy and local policy at the city or county level? So I think there are three main ways. Of course, you may have other ideas, but I'll touch on three ways. One is to characterize the public health burden. So I think that's actually really important because, again, when we hear headlines about the death counts, a lot of times those are just those directly attributable types of impacts. And it's really important to actually do the research that can statistically tease out all the excess mortality and all of the excess types of chronic disease exacerbations, because there really are a lot more health impacts than those that are just directly attributable to the event itself. The other thing that I think is very important is to understand population vulnerability and resilience. This schematic here from the U.S. Global Change Research Program looks at different determinants of vulnerability. And I think with each of them, we can think of those as areas where we can intervene upon. So there's exposure. We could think about how to lessen exposure to the environmental stressor. We could think about how to decrease population sensitivity and also how to increase adaptive capacity. So when we start to understand more about population vulnerability to these types of extreme weather events, we can think about ways to intervene on them and protect public health. And then finally, it's a good way to be able to appropriately target resources. So again, if we identify vulnerable populations or neighborhoods, we can think about where to direct resources more appropriately, and also how to intervene on them from the different ways that those populations are more vulnerable. So I'm going to quickly run through two case studies from my own research. The first is a completed study on heat and health in New York City, and I'm going to talk about some of the impacts that this study had local policy, and then I'll get to an in-progress work. So I first want to mention that well before I was involved in this work, heat was a longstanding recognition as a health burden in New York City. There was a lot of great work done by the New York City Department of Health and Mental Hygiene on this topic, on the burden of heat to New Yorkers, and I collaborated closely with a lot of folks in that department. When I got involved, I was really interested in vulnerability, and this was for a couple of reasons. One, as I said, I think it can inform urban planning. There was a huge initiative to plant 1 million trees in New York City, and so we could think about, if we understand population vulnerability, how to target the places to plant those trees. And secondly, from a scholarly perspective, a lot of the previous vulnerability mapping had not actually used health outcome data. And so to me, I thought this was an important area to actually use health outcome data to validate the vulnerability maps. Because I think, as it was mentioned earlier, we can trust in God, but everyone else needs data, right? So I feel like using the health outcome data gives some credibility and helps, I think, to push your ideas through to policy. So really briefly, we used a case-only epidemiologic study design. This is kind of an efficient way to look at how a non-time varying characteristic, so that could be at the individual or neighborhood level, so things like race and ethnicity or neighborhood characteristics, of which we looked at several. How did that happen? Okay, sorry about that. So we looked at several neighborhood characteristics, including green space, including measures of poverty at the census tract, including the urban heat islands, or differences in surface temperature. So how all of these things can modify a time-varying characteristic, and in this case, our time-varying characteristic was temperature or heat waves, and so we looked at heat waves in comparison to non-heat wave days during the summer season. And we used data from about over a decade period of all New York decedents. Okay, so these are some of the results from that study. So some of the individual characteristics that we found increased the odds of dying during a heat wave were non-Hispanic, Black race, as well as individuals were more likely to die at home during heat waves than in hospitals or institutions. And that could be a marker for many things. It could be a marker for social isolation, as it was mentioned earlier, which has been shown in other studies of heat to be predictive of death. These are some of the neighborhood characteristics. We found that living in greener neighborhoods in the city was protective. So you're less likely to die during a heat wave if you lived in a green neighborhood as opposed to less green neighborhoods. Correspondingly, you were more likely to die in hotter areas of the city, so areas that had a higher surface temperature. And also, individuals who lived in poorer neighborhoods in the city were more likely to die during heat waves. So what we did is we then took all of these characteristics that had been shown to be predictive of dying during a heat wave in our epidemiologic models, standardized them and combined them into an index, and then looked at how that index varied spatially throughout the city, and created this composite heat vulnerability index. And so you can see that these are the areas that are red are the most heat vulnerable, and those are particularly areas of Upper Manhattan, the Bronx, and parts of Brooklyn. Using that combined index score, we then showed that, so if, for example, if you live in one of those red areas in the highest quintile of heat vulnerability, you had about 10% higher odds of dying during a heat wave than if you lived in a low vulnerability area. And since this index has been validated on more recent years of death data, that was not used in our study. So working directly with the New York City Department of Health was wonderful because, for many reasons, but one was that my colleagues there were able to immediately take these results and put it into action. And so the heat vulnerability index was featured on the New York City Health Data Portal. It still exists there in this aggregated form. You can find it online. And then about 2 years after we published the study, the de Blasio administration announced a new initiative called the Cool Neighborhoods New York City Plan. And this was an over $100 million initiative to help curb the effects of extreme heat. So this is from the press release for that plan. And you can see that one of the initiatives, which they're talking about more targeted street tree plantings, it is mentioned in this press release that they'll be targeted in the South Bronx, Northern Manhattan, and Central Brooklyn. And that's because those areas were identified as disproportionately vulnerable to heat health risks, as identified by the city's heat vulnerability index. Our index was also prominently featured in the plan and also informed targeting of several other initiatives within this plan. Okay, I want to quickly move to talk about some current in-progress work, and that is looking at resilience to the health impacts of Hurricane Sandy. So when I first conceived of this study, which was prior to 2017, Sandy was the second costliest hurricane in U.S. history, second only to Katrina. That has since been surpassed, but it still was particularly damaging, and in particular to New York and New Jersey. A lot of the prior health-related research on hurricanes, while some of it does touch on physical health outcomes, a lot of it focuses on mental health outcomes, which we know are extremely important. But as mentioned earlier, I was particularly interested in kind of looking at some of these chronic disease exacerbations, which I think are important to fully account for in the societal burden when we're talking about the impact of severe weather events. The other thing I was particularly interested in is I had started reading a lot about community resilience, and from literature other than public health literature, so from urban planning or the geography literature, and there was a lot of discussion about different metrics and indices that could be used to kind of figure out how resilient a community is to a disaster. Sorry, I keep doing this. I keep hitting this by accident. Okay, very sorry. But I noticed that this literature, these indices had not really been, used with health data. Okay, so they had not been looked at as to whether they could predict the occurrence of health outcomes after a disaster. So I thought it would be really important to empirically validate whether these community resilience indices that were being cited by the national academies and government agencies, if there were, could determine whether a more resilient community had less of a health impact from a severe weather event. Okay, so very quickly, a similar type of methodology. I'm looking at, this is an ecological study looking at county level data. Well, I'm actually looking at individual level data, but then aggregating at counties to look at county community characteristics. I'm looking at New York and New Jersey, but just showing some results from New Jersey today. I'm using data from the Agency for Healthcare Research and Quality's Healthcare Cost and Utilization Project. So it has hospitalization and emergency department encounters as well as their charge information. And as I mentioned, I pulled in some data on community resilience. I decided to use this baseline resilience indicators for communities index, which is cited very much in the community resilience literature. It was developed by a woman, Susan Cutter, who used to be at University of South Carolina. But as mentioned, it hasn't really been used to predict health outcomes after a disaster. And it's a measure of about 49 indicators at the county level across 6 different domains of resilience. So things like social resilience, environmental resilience, infrastructure resilience, different domains. And then also at the county level, I'm looking at this measure published by Rutgers University of storm severity. So it looks at power loss and other damages as a way to try and adjust for storm severity. So this is the how the storm severity varied throughout the state of New Jersey. You can see the really dark areas along the coast were the most severely impacted counties. There are a couple of lighter counties that were less impacted. In the analysis I'm going to show right now, I'm looking at just the 16 darker areas of the map, 16 different counties that were more highly impacted. Okay, so I won't go into these details. I'm running out of time, but I'm happy to talk about the methods afterwards. But basically, within county, I'm looking at the temporal variation. So do we see a surge in emergency department visits in the months following the storm? And then I'm looking across counties to see if that surge the difference in the surge across counties can be explained by these different county characteristics. Looking at several different chronic disease exacerbation, so ED visits for several chronic diseases. I'm going to show some results from chronic obstructive pulmonary disease today, which is the third leading cause of death in the U.S. It's can be emphysema or chronic bronchitis, and it can be particularly impacted with a hurricane event because people are either on oxygen therapy for their therapy, or they might have a medication disruption. So this is something that we think could be very likely impacted by a storm. And I'm adjusting for season and secular trends in all of this analysis. So this is just the raw data you can see for chronic obstructive pulmonary disease, the solid line indicating the sandy year. So you can definitely see the surge in the raw data. It levels out after several months back to the baseline of years that come before and after. And this is, in the months following the storm, the percent increase in COPD-ED visits across the different 16 counties. If we aggregate, we can see an increase across all of these counties to varying degrees. If we aggregate that, we see about an 18% increase in the monthly ED visits. It does vary spatially. And so then I kind of wanted to tease apart and see if we could explain that spatial variation with any of those county characteristics. This is those same percentage increase effect estimates and sorted by the resilience metrics. So the more vulnerable counties up at the top, the more resilient counties at the bottom, and we can see, maybe there's a pattern there. When I put both the storm severity and the resilience into the model as modifiers, we do find that actually the resilience indicator explains about 3% of that variation across counties, and actually more than the storm severity. So for each standard deviation in resilience increase, we see about a 3% reduction in the effect of the storm. So just a very quick hypothetical, that doesn't sound like a lot in terms of a 3% reduction. It might be about 23 less ED visits, but that's actually could be a lot of healthcare dollar cost savings. So I'll just wrap up by saying that there are broad health implications of these types of climate-related events. They're not always immediately understood. They're more than what's directly attributable to the storm, and all populations are definitely not affected equally. I think it's really important to think interdisciplinary in terms of partnerships and data, and this type of research can help us quantify the burden to society, understand points of intervention, appropriately target resources, and justify public health and community resilience investments. I just want to highlight some funding sources and lots of wonderful collaborators, and thank you for your time.